So once again, we want to welcome you to this webinar. Welcome to everyone to this vital webinar on antimicrobial resistance, or you can call it AMR, and the role of advanced diagnostics, proudly organized by the Diagnostics Equity Consortium, which is a collaboration or an initiative of the Pan-Africa Treatment Access Movement in collaboration with Georgetown University's O'Neill Institute. And today we are gathering here to address a public health crisis of monumental proportions, AMR. It is a threat so severe that the World Health Organization has named it among the top 10 public health threats facing humanity. It is so severe such that in 2019 alone, AMR directly claimed over 1.2 million deaths and then contributed about 4.9 million deaths. And you know, all this is actually surpassing the toll of HIV, TB, and malaria combined, at least in that year. And guess what? It is not only devastating, to the loss of lives, but it also has economic implications. The World Bank has estimated that by the year 2050, AMR could result in an additional $1 trillion US dollars in healthcare costs and between 1 trillion to 3.4 trillion in annual GDP losses by the year 2030. All these figures are truly highlighting the urgent need for action, and at heart of this battle is the need for universal access to quality diagnostics. So here today, we want to talk about the role that, advanced diagnostics can play in combating AMR. But as civil society organizations, we do have a unique position to drive this change, advocate for ensuring access to diagnostics, and ensure that we are saving lives. So right now and today for this webinar, we will make sure we are trying to lay ground for understanding antimicrobial resistance and the role of advanced diagnostics in combating this disease. We want to explore in combating this issue. We want to explore the critical role of diagnostics in combating this threat, but also to discuss how we can participate, how we can make a contribution as civil society organizations. And the contribution really needs to be as tangible as possible, as you can imagine. And we are here to rally, the advanced diagnostics as a cornerstone in the fight against AMR. But to help us unpack all this that we have today, we have a distinguished panel of two this afternoon, this morning. And to help us, we are thrilled to introduce to you one of our esteemed panelists. First is Professor Gunturu Rivathi, who is the head of clinical microbiology at the Aga Khan University Hospital in Nairobi. She's a powerhouse in the field with over 150 publications on topics ranging from salmonellosis to antimicrobial resistance, and her extensive experience and involvement in national and international health initiatives makes her a key voice in this discussion. But to join her as well, we have Tapiwa Nashe Kujinga, who is the director of the Pan-Africa Treatment Access Movement. You can call it PATAM. And he has been dedicated in this fight for over 30 years of fighting for equitable access to healthcare, including his pivotal work on HIV, on diagnostics, and working also on the national AMR program in Zimbabwe. So together, we will delve into the critical issues at hand and explore the actionable solutions. And hopefully by the end of the webinar, we'll be able to see what is it that we need to do to collaborate, to work together towards ensuring that there is equity in accessing diagnostics, especially in fighting this monster, AMR. So thank you once again for joining us. And just to kick us off, I will call upon Professor Gunturu. But before I call upon Professor Gunturu, please be reminded that we will have a Q&A session. Nevertheless, please feel free to write down in the chat or in the Q&A box what your question is as we get along. Some of you may have burning questions that you cannot wait, and we are open to that. Please feel free to write them down in the chat box. So I'll hand over to Prof. Gunturu, who will take us through AMR and one-on-one, as well as diagnostics around AMR. Thank you so much, and over to you, Prof.
Thank you very much, Alice. Thank you so much for that very kind introduction, and also very nice preamble to this topic to make it easy for me. What I'm going to speak, you have already highlighted the problem. You are able to see my screen?
Yes, Prof, we can see your screen. Your voice is a little soft, Prof.
Is it okay now?
Just a little louder.
Is it okay now?
Better.
It's better now?
Better indeed. Yes.
Yeah, I have put it on the maximum sound.
Yes, it is good.
Yeah, thank you very much. Just wanted to thank the organizers. And that is Invocation, the goddess of learning and wisdom, music and arts. I worship every day. This is an ancient belief. And this is our webinar today. And very happy to be participating in this webinar. And I really value this opportunity to be addressing this gathering today. And good morning, good afternoon, good evening, wherever you are, my dear friends. And I'm very grateful to the organizers for taking time and effort to organize this webinar. This is my credentials. Alice has already introduced me. And we have these pictures of the microbes. I have no conflict of interest related to this presentation. These are the resources for my presentation. I have prepared the slides based on all open resources, journals and websites, professional, and also textbooks, and very established organizations like WHO, CDC. And maybe in this gathering today, I'm fortunate to have members of civil society, prescribers, patients, maybe opinion leaders, academia representatives, healthcare authorities, some of you, maybe a lot of you playing in the arena of health, and maybe you also have some antibiotic users in this gathering. So it's my good fortune today to be talking to you. What are my objectives? I want to attract attention to the pandemic, which already is being done. I think we are all aware of it. Then provide some insights into what exactly is microbiology. That's what I was requested to do. A sneak peek into the world of microbes and the challenges we face in diagnosing these infections, because unless we know this is the infection, this is the bug, we cannot direct the treatment. And that is where unnecessary or excessive antibiotic use is going on, which promotes antimicrobial resistance. So this is the famous slide from O'Neill report 2016, and this has already been alluded to, the millions of projected number of deaths. And then AMR is a very complex problem, and this topic is very immense, and I don't pretend that I'm expert enough to put all this stuff into 20 minutes, but I'll try my best. This is Olympic Games which recently finished, and the athletes who were swimming in the river in Paris, they all came down with vomiting and diarrhea. And why? The water is polluted. The river water is polluted with Shigella flexneri. This Shigella flexneri was called MDR, multi-resistant bug, and it is resistant to the routine antibiotics. And to treat these people who are infected, the athletes, very strong swimmers, they all came down with vomiting, diarrhea, fever. They had to go back. Some of them couldn't participate. in the games. So that is the importance of AMR quickly. This is on the website, WHO website, dangerous Klebsiella pneumoniae. This is a type of bacterium. This one is again resistant to the medicines, lot of medicines, and it is also having a special virulence factor. That is, it is able to infect people very quickly. Now, this is another news I want to share with you. Most of my presentation is pictorial to make it easy to understand, because you are all not, all of you are not microbiologists or doctors or professionals. This stuff may sound sometimes a bit difficult. So this is one of the projects funded by Fleming Fund called MAP project. And this is the news they published when they actually analyzed the data that Africa is flying blind, because this is the state of healthcare infrastructure quickly. This is Ebola wards in Sierra Leone. And this is just 20 kilometers from any city center. This is the discard from the hospitals, which is not being properly discarded. These are our daily issues. This is where the governance has to be strengthened to take care of these things. This is our reality in Africa. This is a child drinking water from the same pail his cattle are drinking. So this is our reality. We cannot deny this. We are living with it. And something needs to be done. This is now CDC, where we get all the wisdom from, and the Emory Healthcare Center, where you have the ambulance. Look at the infrastructure there. Now, this is a very recent webinar which is on the website. You can register if you want. National Academies of Science, Engineering and Medicine. They are conducting a webinar on advancing equity in diagnostic excellence to reduce health disparities, a workshop. This is all about American health system, where the disparities are so great, so that this think tank is doing this webinar to take care of those disparities. So it is not just Africa, it is all over the globe. That is the truth we have to face. This is my hospital, quickly, Aga Khan University Hospital, where I work. This is our front entrance. This is a private university, not for profit. All the money earned is spent in the medical college to give scholarships and to maintain the infrastructure. This is our college building. We have an undergraduate program. We are basically, so far, we have been a postgraduate program. This is our ICU, intensive care unit, where it is one-to-one nursing. This is the ICU isolation room, where you isolate a COVID patient, a TB patient, or an influenza patient. This is an isolation room. This is my laboratory quickly, the core laboratory, my molecular biology laboratory. This is where my techs are working, and automated bacteriology analyzer and the molecular diagnostics I have. This is the ICU. Why I'm showing ICU to you is this is the field. This is the agricultural land where multi-resistant bugs are cultivated. How they are cultivated? Because we use a lot of antibiotics, and antibiotics promote. The more you use antibiotics, the more resistance you promote. The antibiotic resistant bugs are cultured or cultivated in this particular agricultural field. This patient is on so many gadgets, he's on so many medications, and he's on so many antibiotics. And then you prepare resistant bugs in his body. From there, they spread to the other patients if you are not careful, and they also spread to the community. When he goes home, he can take them home, he can infect his family, all those things. So this is a field, agricultural field, where the MDR bugs are being cultivated. This is the lot of publications, lot of wisdom we already have about the state of laboratories in Africa. Lot of publications people have studied from the developed world, and they have published all these papers. Let us recapitulate. AMR is a very, very complex problem, and the complexity has been worsened by the climate change. Look at the climate change, terrible climate change, and it is producing new pathogens, empowering the older pathogens to create more pathogenicity, acquire resistance, and also go into other ecological corners, which they were earlier not there. So the climate and infectious diseases is now a super specialty. This is the reality again. these are antibiotics. This is enrofloxacin. This antibiotic is sold in kilos. 1 kilo for $15. 100 kilograms packets are available. This is how the veterinarians buy antibiotics. They don't buy in grams and milligrams. Like in a hospital, I use the same antibiotic for a patient with urinary infection, 400 milligrams, 3 times a day for 3 days or 5 days. So the whole treatment may not be 4 to 5 grams. Whereas in veterinary science, they are using kilogram, 15 kilos, 20 kilos, 100 kilos for $20. And this is how the antibiotics are used. So unless we take care of these, we are not going to control the resistance. Resistance follows the drug like a faithful shadow. This is what was said by Paul Ehrlich, grandfather of microbiology. The key to rational use of antimicrobials will be to treat on the basis of knowledge. And how do you get the knowledge? When you have diagnostics. If you don't have a lab diagnosis, there is no evidence. If there is no evidence, you are blindly treating with a lot of antibiotics. So this is again the tragedy of the Olympic athletes. Now, we are told that drug resistance is going to be worse than COVID by the experts like Dame Sally. And this is an experience of a patient who suffered AMR. This is a cancer patient. She went into septicemia and she had to be treated with antibiotics. She had an MDR bug. This is on the YouTube. There are many, many stories of the AMR victim patients, and they are very pathetic. This cancer patient, she was treated fully for cancer, but the AMR bug, they could not treat. The doctors told her, you are going to die, but somehow she survived. So this is a personal experience of Laila Hudson in UK. So this has already been alluded by all 4.95 million deaths. Let us skip this. We come to now, diagnostics are essential for implementation and population level surveillance of 3 major global health priorities: universal health coverage, antimicrobial resistance, and global health security. All these 3 are not possible if we do not have lab diagnostics. This we know very well. And we also have all this wisdom. This is a course, online course, role of diagnostics in the antimicrobial resistance response. We know this very well. And this is the Lancet Commission publication. Just to show you, just to remind you, this is very popular. All professionals have read this. The essential diagnostics availability in the low middle income countries. And the Lancet Commission on Diagnostic Transforming Access to Diagnostics. We have all this wisdom. This paper has been written by the top class experts in this field. But this commission has said that 47% of global population has zero access to diagnostics. It has already been said. Diagnostics are underfunded because their central importance is unrecognized. This has been already said. Now we need action. We don't need any more data, any more evidence on this. The latest is the MAP project funded by Fleming Fund, 14 African countries. These are all the documents. We have a document for each country. We have one for Kenya. Look at this, ladies and gentlemen, very pathetic. It is that they studied 50,000 laboratories and only 1.3% of them can perform bacteriology testing. That is, they can do AMR testing only in 1.3% of these labs. And all these labs are there, they are counted as 50,000. And isn't it pathetic that only 1.3% can do the AMR testing? So for LMICs, this is what it is. This boulder is AMR control. These are all the emerging pathogens, climate change. You have viruses, you have fungi, you have all these Ebola, you have now monkeypox outbreak all over. And the LMICs are trying to hold this boulder. How much they will be able to hold? Ladies and gentlemen, we really don't know. Okay, this is my laboratory on the left side. On the right side, you have a public laboratory where a tech is sitting under the tree. These are all the patients. He's trying to do a lab test, some stool or urine. He's doing microscopy. He's trying to give a report to this doctor. Just imagine that is where still we are. This is how data is collected. Look at these forms and look at these forms. This is how a district hospital, county hospital is collecting data. This will not be possible for WHO to go and gather any data from this particular center. This one is slightly better, the next one. And the right side is again a computerized printed form. The other one is electronic health records, which we have in the developed world. This is what I use in Aga Khan University Hospital. We are on a very elegant Meditech system, which is an American system. And that is because my hospital is JCIA accredited, American accreditation. My laboratory is College of American Pathologists accredited. So these are all the documents we created for laboratory capacity building through Fleming Fund. And all these are the Ministry of Health officials. But what is going on in the laboratories is still, we are not very sure. So these are all the microbes, the bacteria, which I want to take you to quickly look at them. This is a virus, this is a fungus, these are the bacteria. Quickly to go through basic microbiology. We have bacteria which are called cocci, they're round cells. They are in clusters. They are also in chains. We call them streptococci. The clusters are staphylococci. If they are in pairs, we call them diplococci. They are a curved bacilli vibrio cholera. The one which causes cholera is a curved bacilli. You also have anthrax bacilli, which have spores. And you also have the syphilis bacilli, which are like spiral, leptospira. It's a jaundice causing bacteria. It is in spiral form. So these are all the forms, fancy forms, the bacteria take. On this slide. We have all those pictures. And then this is how bacteria develop and multiply. Quickly, one cell within a few seconds becomes 2 cells and divides. This whole thing takes a few seconds. And by the time you have 5 minutes, you have millions and millions of bacterial cells. And the cell has a plasmid. This is where the antibiotic resistance develops. And the bacterium now is able to survive in the presence of an antibiotic. The bacteria also produce what are called exotoxins, diphtheria, tetanus, gas gangrene. These are all exotoxins. The toxins are released by the bacteria. There are again endotoxins like typhoid, E. coli, the urinary tract infection producing bacilli. The bacillary cell wall itself is a toxin. That is called endotoxin. This is what kills the patients with sepsis in ICU. The exotoxins also kill the patients if they are not appropriately treated, and we don't have diagnostics to know whether this bacterium is producing exotoxin or it is producing endotoxin. So unless we know, we have a lab test, we have detected this organism, we will not be able to treat the patient appropriately. The bacteria, they require nutrients, temperature, water, and energy, and then they survive. They find all these things in the patient's body. And then we can neutralize the bacteria. We kill them by heat, drying, and lack of nutrients and antiseptics and disinfectants. We also kill them with antibiotics inside the patient's body. Outside the patient body, we use a disinfectant or antiseptic. The spores, which I talked about for anthrax, they can be killed only by some machinery. You cannot kill them just by putting a chlorine solution or iodine solution. You have to autoclave them with a machine or you irradiate them. So that is where the difficulty is. And some of the organisms, they live inside the cell, like chlamydia, rickettsia. These cause the other diseases like Rocky Mountain spotted fever, chlamydial urethritis. They are very, very important infections. Mycoplasma causes pneumonia, which can kill the patients. So these organisms are inside the cells. They are difficult to grow. You need very expensive diagnostics, elegant diagnostics. These are the viruses. This is HIV virus, this is hepatitis virus, and this is another influenza virus, nucleocapsid. It is all these matrix proteins, antigens, and they have the virulence factors, that is to produce the pathogenicity, infect the patient, make him sick. So these are the viruses. And we also have another agent called prions. These prions are not living bodies. They're just protein molecules, but they can infect people. They are very difficult to treat, very difficult to diagnose, very difficult to get rid of, and they cause mad cow disease in the veterinary sector. They also cause a variant disease in the humans, and we are really struggling with an outbreak of this kind of infections. These are the fungi. The fungi are filamentous. They can be yeasts or they can be molds. And these are really now posing a problem by developing antifungal resistance. And these are protozoa. You have amoeba, you have blood flukes like trypanosoma, you also have plasmodium, the malarial parasite. These are also microorganisms because we have to see them with a microscope. And these are the big parasites, the worms, the roundworms, the tapeworms, and the trematodes. Now, all these can infect, all they need antimicrobial drugs, and resistance is problem in all these organisms. Now, look at this, resident transient microorganisms. These organisms are normally present in our body. They are present on our skin. They are present on all our mucosal surfaces, in the gut, in the nose, in the mouth, and everywhere, in the genital mucosa, in the stomach, in the intestines, in the lungs. They are present everywhere. But the problem is, these bugs can become pathogenic and infect us. And the pathogens can go and colonize in these sites. So that is another problem. You need diagnostics to recognize. Organisms are transferred by hand touch. So usually hand hygiene is very, very helpful for us. This is just a cycle. I won't go into the details of how an organism enters the body, infects the person. A person can recover or a person can get sick up to the point of death. This is a cycle of infection, how organisms are invading us. These are the classes of antimicrobials, antibiotics or antibacterials, antivirals, antiparasitic agents, and antifungals. They are very self-explanatory because we have 4 classes of microbes. We have 4 classes of drugs against each class, and all of them are together called antimicrobials. These are the classes. The current discussion is usually on antibiotics or antibacterials, but it concerns all of them. We have a big problem of anti-parasitic resistance and anti-malarial drugs. We have antifungal resistance. We also have antiviral resistance against the flu virus. The drugs which are for flu virus are no longer working. So this is, I won't go into the details. This is a bacterial cell. The cell is able to resist antibiotics by various mechanisms. This is a bit technically deep. I don't want to worry you, but just to know, it is good that it has various mechanisms. Yellow is one type of mechanism, green is another one, blue is another one, red is another one. There are various mechanisms the bacteria have developed how to resist the antibiotics. What is the importance of antibiotics? You need to treat them, all these conditions: bacterial pneumonia, UTI, meningitis, tuberculosis, typhoid, Lyme's disease, osteomyelitis, gonorrhea, diarrhea, so many. And these are the procedures in the hospitals. Without antibiotics, we cannot do. We cannot do organ transplantation. We cannot do surgery if I don't have an antibiotic. Cancer treatment is impossible, ladies and gentlemen, if you don't have antibiotics working. Childbirth, the child requires antibiotic. If he is born with an infection, the mother requires antibiotics if she gets infected. So all these things, we need antibiotics. Complex problem again. And some infections are preventable, some are more preventable. And it is a very, very complex, entangled thing. Look at some of the infections. This is carbuncle. A diabetic gets this. This is a viral infection and the pustules. You need a diagnosis, how to treat. Look at this child's leg. It is swollen. It is terrible. This child can die if you don't diagnose and properly treat with an antibiotic. Look at this. This is gas gangrene. This patient is at the gate of heaven. Unless you diagnose this condition and quickly treat him, it is impossible to treat this patient. Look at this wound. And I will quickly show you. These are the type of samples we need to collect in the lab. And this is a training element, ladies and gentlemen. We need sound training to provide sound diagnostics. And these are the bacteria. Just have a look at these bacteria. This is how we grow them in the lab. These are mixed bacteria. These are pure bacteria. All of them are different bugs. They all produce different conditions. This is two types of bacteria. The pale one is called Elizabeth kingia. This one is a very toxic organism. It is already resistant to so many drugs. We have a patient with this organism. All these plates are from my lab. This is another organism. Look at the pits. It produces pits on the plate and I recognize, oh my God, I have this bug. This is called Serratia marcescens and it produces purple color. The minute I see this plate, I know, my God, I have Serratia in this patient. How to treat this guy? Because this resists antibiotics like anything. Look at the mixed organisms. The yellow one is the pathogen. This is called Staph aureus. If this is in the bloodstream of my patient, I'm terribly worried because this patient can die. And this is another bug. Look at this. This is Proteus. It swarms like waves. This is another bacterium and it is a very dangerous bug. This is a sheep blood agar plate we use in the lab. And you see the clearance. This is called hemolysis. That is lysing the blood cells. That is an organism. This is urinary tract infection. These are all the bacteria which are mixed in culture. It's a special technique to isolate them. This is how we test antibiotics on culture plates. All these discs are antibiotics. The background is bacteria. We put the antibiotics, we test, and now here the clearance says that the bacteria have been killed. Around this disc, there is no clearance. The bacteria are not killed. That means this drug, the bacterium is resistant to. This drug, the bacterium is sensitive to. It's not that simple. We have various standards before we are able to read this plate. This is how my techs read the Kirby bar plates manually. This is a laboratory scenario where the antibiotic sensitivity tests are being read. And this is a very serious training element and we need to build capacity. This is called gram stain. We see the bacteria. You see these tiny red dots. They are all the bacteria. This purple chains is the bacteria here. This is a diagnosis. We can see this picture and treat this patient with a specific antibiotic. These are all the conditions we take samples from and we know what these conditions are. This is again purple chains of bacteria and this is my laboratory where the bacterial testing is going on. Quickly, I'll show you some latest diagnosis. This is about blood cultures. These blood cultures go into a machine. I want to share with you quickly 4 types of lab testing: mass spectrometry, magnetic resonance. This is a latest technique which is available in the developed world and not very difficult in Africa, and nucleic acid amplification. These are 4 technologies. This is the Malditov technology. It can give bacterial identification in 5 minutes, even less than 5 minutes. My lab is now trying to acquire this machine in a couple of months. This is the automated bacteriology analyzer. Several labs are already using in Africa. My lab also is using. It makes the life very easy. It gives a good identification and susceptibility testing, but expensive. This is fish technology to see the microbes quickly, turnaround time, quickly diagnose, but very expensive technology. These are the PCR techniques which are available, ladies and gentlemen, pretty expensive, but the private sector labs are using them and the funders are able to fund them, but the consumables are very costly. So the labs, the public sector labs are unable to fund these technologies. Even if donors have given the machines, the reagents are not there. So these are examples just to share with you. These are pretty small machines. They give a quick turnaround time. In 2 hours, you know this patient has influenza. This patient has group A streptococcus. And then T2MR Diagnostics is another fantastic machine. Very quick turnaround time. It gives directly the results within very short turnaround time. So I want to end this presentation by sharing with you something WHO has put up on the website about people-centered approach to addressing antimicrobial resistance in human health. It proposes a package of 4 core interventions. What are they? Prevention of infection, access to essential health services, timely, accurate diagnosis, and appropriate quality assured treatment. That is the package. And in that package, the pillar 4 is timely, accurate diagnosis. Ladies and gentlemen, we are asking for diagnostics to be supported. And this is top class of American universities which are practicing medicine with a side of mysticism. They are promoting some herbal remedies because the antibiotics are not working. We are really desperate. This is from an American website. They have what is called parallel medicine, and they are promoting some herbal, Indian herbal medicine, Chinese herbal medicine, right across a standard university hospital. In Canada, US, you have this herbal medicine. What is the summary of my presentation? Antimicrobial resistance has reached dangerous level. We need action on the diagnostics. Without diagnostics, we are not going to fight this war. And accelerated access to diagnostics is imperative. We have no choice. Thank you so much. Hand washing is at the center of preventing infections as well as MDR infections. Thank you very much. Thank you for your attention.
Great. Thank you so much, Prof. I could pause that I am a scientist at this point after going through some of your slides. Thank you so much for taking us through the basics, the foundations of antimicrobial resistance, as well as diagnostics and what is needed. For those who have just joined us, you are welcome to this webinar. This webinar has been organized by the Diagnostics Equity Consortium, and the Diagnostic Equity Consortium basically aims to create a unified advocacy agenda to enhance diagnostics capability, particularly in sub-Saharan Africa, where we see very limited access to quality diagnostics, as ably put forward by Prof. Gunturu. And taking you or moderating this session today is myself, Alice Mutebi Kayongo. I am Senior Associate at O'Neill Institute, specifically with the Center for Global Health Policy and Politics. I am so excited to listen, to learn, but also looking forward to what is coming on next and to present to us the other side of it. We have listened to the science, and Prof has indicated that it is not a choice. It is imperative that we actually need to act so fast in ensuring that we have access to diagnostics. So we have Tapiwa Nashe Kujinga, the director of PATAM, or Pan-Africa Treatment Access Movement, who is going to take us through what has civil society done and what else is there to be done? Where are we seeing the gaps and what should be done? And thereafter, we will get into discussions. But as Tapiwa speaks, if you have any question, please feel free to share in the Q&A chat so that Prof can be able to respond as we go along. And for any questions that we may not be able to get into or details that we may not be able to get into this time, please be reminded that we are organizing a series. This is the first. We will have another next month where we will dive deeper into these issues. So please just be rest assured that we have much more in store for you. Otherwise, for now, I'll hand over to you, Tapiwa, to take it on.
Thank you. Thank you so much, Alice, and good day to all the colleagues on this webinar. I want to especially recognize one of our board members, Mother Tolana, who is on this call, who's on this webinar. So my presentation is going to be looking at the civil society aspect of advanced diagnostics in the AMR sector, and it's going to be quite short, but I'll be borrowing quite a bit from the presentation by Prof. Next slide. So I will not repeat some of the statements made by Professor, but just to restate that the global AMR pandemic is one of the 10 most serious global health crises in the world today, and you can tell from the mortality rate that we are actually heading for a crisis. The Jim O'Neill report estimated that by 2050 we should be facing a mortality rate of about 10 million people per annum, and already we are at 5 million. So that's, quite serious. And in the Global Action Plan for Antimicrobial Resistance, a whole of a society approach was proposed because AMR is so complicated. It is multi-sectoral in nature. And I think, Prof repeated it twice, in terms of addressing the complexities of this pandemic. With HIV, we knew exactly the dynamics, we knew the epidemiology. With AMR, it is so varied, it's so complex. So what we've seen, in contrast to HIV, in contrast to COVID-19, global collaboration has been very slow. We are not seeing, that momentum that we need to address AMR. And one of the gaps that still remains in terms of addressing AMR is the availability of advanced diagnostics, which are not only able to rapidly identify pathogens, but also to determine the sensitivity and resistance profile, especially of priority pathogens. I think Prof talked about the results from the MAP study, which talked about, bacteriology testing being available in 1.3% of the surveyed laboratories, 50,000. That's really serious. And yet we're talking about, bacterial infections being the most serious out of, the 4 pathogens. Next slide. So what is the challenge in terms of advanced diagnostics for AMR? So there are so many challenges. I'm just going to list a few of them. You'll find that in many countries, and I'm talking about low and middle income countries, they sometimes are no budgets, right, to support the purchase of diagnostics and related commodities like your reagents, like, for example, to do servicing of machines. And we also see low levels of technical diagnostics experts who are able to conduct the complicated procedures. I mean, there are so many procedures, and Prof went through that. There are so many procedures that are needed, and there is need for laboratory scientists, laboratory technicians to be able to do that. But what we see in many low and middle income countries is that most of these skills are lacking, especially in the public healthcare system, and they are quickly snapped by foreign countries in the north who can pay them more than they are being paid locally. And there's also an over-reliance on foreign donors such as the Fleming Fund. So when you rely on foreign funding and it doesn't come, then there's a problem. And the Fleming Fund, unfortunately, does not cover every low and middle income country. And again, there's also, substandard laboratory management information systems. And these are not able to accurately analyze the data coming out of laboratories so as to allow AMR programs to develop policy positions. Prof mentioned about, the fact that 44% of the laboratories surveyed use the paper-based systems. Now, when you look at the, the mass of laboratory results that are handled in the public healthcare system, then you need some sort of, machine-backed systems to be able to analyze. And if you are using paper-based methods, then you are not able, for example, to determine things like epidemiology, to determine, things like, the prevalence, the incidence, and so forth. Next slide. So we've got quite a lot of challenges, and I think I cannot even be able to outline them all. So I'll just briefly outline our experience in the AMR sector. We started in 2015, and we achieved some milestones, which include starting up the national AMR program in Zimbabwe. We worked with a number of partners and stakeholders like Africa CDC and REACT to raise awareness on AMR to CSOs working in the various sectors. Now, AMR is not only human health. AMR touches on animal health, it touches on agriculture, it also touches on the environment. So in HIV, we talk about just one sector, the human health sector, COVID-19 in one sector, but with AMR, you find yourself being surrounded by these experts from all these sectors, and sometimes the language is different. So there is need to bring all the sectors together, and that's what we did. Unfortunately, our plans were, disturbed by the COVID-19 pandemic. We also worked on the Zimbabwe AMR situational analysis and national action plan. We were part of the national Zimbabwe AMR core group. Next slide. And we're very much involved in education and awareness. So we're heading the Education and Awareness Technical Working Group. We were the secretariat, so we're organizing meetings of the technical working groups, including meetings of the Laboratory and Surveillance Technical Working Group, where all the issues around diagnostics were being discussed. And we're also involved in developing policy positions with regard to the laboratory component within the broader AMR response, and also resource mobilization. Next slide. So yeah, we were quite central to the program as it was in its infancy. So what initiatives were involved in pertaining to the laboratory? So I think the first project was the AGISA project, which was focused mainly on two pathogens, which were extended spectrum beta-lactamase, ESBL producing E. coli or Escherichia coli, and the Salmonella species, which includes the typhoidal and non-typhoidal Salmonella. And samples were being collected from the human, animal, food, and environmental sectors. We also included Campylobacter, which is specifically, a foodborne pathogen. And these isolates were subjected to antimicrobial sensitivity testing in the various laboratories, and the results were quite, quite interesting. It showed quite, a huge burden of resistance in all the pathogens, especially on E. coli. Next slide. And just to mention that ESBL, producing E. coli means that there is, a lot of resistance, gram-negative resistance. And this is a picture of, the AGISA advisory committee and the some of the stakeholders. And I'm in front, second from the left. Next slide. So okay, the next one was the glass project. So there was no intervention here, but we started collecting samples, antibiograms, and submitting them to the WHO global system, which which was set up for the purposes of providing a standardized approach to the collection, analysis, interpretation, and sharing of data by countries. And so we started submitting the results from antibiograms with effect from November 2015. So at the time, there were 9 sentinel sites which fed into one national coordinating center. Next slide. So the program is grown, and the GLASS system produces reports every year. And then in the animal sector, we had what is called the ATLAS, the Assessment Tool for Laboratory and AMR Surveillance System. And this is a tool which is used to analyze, to assess or define targets for the improvement of national AMR surveillance systems in the food and agriculture sector. So we had a visit from the FAO Global Office, which assessed a number of veterinary laboratories in Zimbabwe in November 2017 and staged them in accordance with the tool. And it was clear that our laboratories needed more capacity. Next slide. Okay, so that's a picture of the ATLAS group. I see Mr. Dr. Mfanda is standing on the right, extreme right. Next slide. Okay, so we also had the WHO Tricycle project, again, looking at ESBL E. coli, and this was touching, you know, the human health, the food chain, and the environment. And ESBL producing E. coli was found across all the target sectors. Next slide. And as I said, ESBL producing E. coli is very highly resistant. So we also had the Flaming Fund project, which awarded Zimbabwe a grant of $4 million to strengthen the surveillance sector. And a total of 14 laboratories were equipped with capacity to conduct sensitivity and resistance testing across all the sectors. Next slide. So this gave us a lot of experience in terms of, you know, the laboratory sector within, you know, the AMR response. And some of the lessons we learned is that, you know, AMR is a pandemic on its own class. And Prof has mentioned that. It doesn't result in sickness. It can only be detected in the laboratory. So it is important that the laboratory be strengthened, the surveillance sector be strengthened in order to be able to detect resistance. You may be as healthy as you can, but you may have developed resistance to some pathogens. But data on resistance is still scant, and we need a huge scaling up, you know, on in this regard. And the intervention of civil society, especially in advocacy, is really critical to ensure sustained advanced diagnostics for AMR. Next slide. So I'm just gonna skip some of the some of my slides. So what can civil society do, right? I think it's important to understand your national action plan. Almost every country has got a national action plan, and identify the strategic priorities, right? And it's also important to understand and peruse the AMR Global Action Plan, because it is the blueprint for all the national action plans. Next slide. And in perusing the national action plan, it's important to understand, for example, in the laboratory sector, in the surveillance sector, what is being proposed, right? And the civil society, we need to have an understanding of the commitments which were made by our leaders. And I've listed some of the commitments here. You can read them. This presentation will be available. And also to understand the national leadership for AMR, you know, to understand who are they, and then you can start engaging with them. Next slide. Okay, so some of the important steps, you know, like activities or advocacy steps or strategies with respect to diagnostics. For example, identifying critical strategic priorities relating to the sector, establishing level of implementation, what has been done, establish whether the country is receiving external support from, you know, Flaming Fund or some of the funders, and establish whether the surveillance and research technical working group is active. Next slide. And this should be my last slide. Next slide. Okay, so my final thoughts, right? Again, the AMR pandemic is big, right? It's so huge, it's so complex. Civil society needs to be involved at all levels, right? And your participation, you know, is really needed as a start to ensure that advanced diagnostics for AMR are available at all levels. So thank you, colleagues, and I hand it back to Alice.
Thank you so much, Tapiwa. Thank you so much for taking us through that. I see that we are only 4 minutes before the end of this webinar, and I know that it has been, you know, quite a handful that we, you know, we may not be able to cover everything today, but like I mentioned, we will be able to have another session next month and possibly thereafter. I would want to have only 2 responses, one from Professor Gunturu and another from Tapiwa responses, as well as your closing remark. And Professor, do you have a question on how can we change medical protocols of antibiotic prescriptions and monitor it? As you respond to that, kindly give your closing remarks as well. Thank you.
Thank you very much, Alice. Somebody wanted the link. I have posted the link on the chat for that particular reference. It's a very nice reading. For the protocols and auditing prescriptions, we have methodology, internationally accepted methodology. There is an open resource called Global Point Prevalence Survey. Just put Google Point Prevalence Survey, Global Point Prevalence Survey. It will take you to all the tools, how to check the protocols, how to audit the prescriptions. You can audit prescriptions in inpatient, outpatient practice, special areas, and all that information is very well available. It's an open, free resource. So just go to Global Point Prevalence Survey. And that is my answer to the question. My closing remarks is lab diagnostics has been recognized. I've shown you, I shared with you all those Lancet Commission, all the publications, but action is not being taken. It's only Fleming Fund which is able to use some money for reagents. Rest of the money is for buying machines. The machines are there, but the reagents are not there. The government is not able to sustain them. We need some sustainable investment, governance, local governance, and responsibility to take the diagnostics further. Without that, we are not going to fight this battle properly. We pretend that we are fighting, but we are really not. We're fighting without information, in the blind. Thank you. That is my closing remarks. And thank you all participants, dear friends and organizers. Thank you very much. I'm very happy to have participated today. Thank you.
Great, great. Thank you so much, Prof. Gunturu. And to Tapiwa, as you give your closing remark as well, what is it that we can do together moving forward? We have listened to Professor Gunturu, we have listened to yourself, but what else is missing that we are, why are we still not where we ought to be? And how can we work? What can we do together? Tapiwa, you're on mute.
I'm so sorry. Yes, so thanks for that question. It basically takes me back to the HIV pandemic, where we organically started to organize. I mean, there were advocates, activists in countries who did not need anybody to come to them to start organizing. They started doing it on their own, and a movement was built up, and we achieved quite a lot. The success which has been recorded in the HIV response is mostly due to civil society. Until we came in, our governments, our stakeholders were dragging their feet. I remember there was 3 by 5. They were proposing to treat 3 million people by 2005, which is not enough if we looked at the numbers. And right now, we're talking about universal access. So what do we need? I think we do need to create another movement for AMR. We need to start coming together. We need to start, collaborating, not only human health, but animal health, agriculture, the environmental sector. We need to get organized and we need to start pushing. Diagnostics, when I look at the HIV pandemic, for example, the diagnostics which were there, when we came in, during the early 2000s, are way, way ancient than the diagnostics that are available now. Now we've got point of care. Now we've got near point of care. Now we've got self-testing. People can actually test themselves for HIV in their own homes. But that was because of civil society. I know this is an issue which Sharon, for example, has really been very passionate on. So we can do the same thing. We can push governments to develop, put money in R&D, develop, diagnostics. We now have other diagnostics. I'm seeing Praveen Gautam talking about lateral flow assay being available for AMR, and these are good diagnostics. So I think we need to create a movement. We need to come together, and the Diagnostics Equity Consortium is open, for people, organizations, which want to join. We are available, and we can actually, work together on this. So yeah, I know I've said quite a lot, but I think it's important that we really work to ensure that the AMR pandemic is curtailed. Otherwise, we are looking at a real serious global health pandemic. Thank you.
Thank you so much, Tapiwa. And just on that note, we're about to wrap up. But before we do that, I want to leave you all with a call to action. And my very simple call to action is just to reiterate what Tapiwa has just said, that please join the Diagnostics Equity Consortium, or you can refer to it as DEC, so that you can become part of the transformative change that we are all striving for. If you haven't already shared your email address, please drop it in the email in the chat. We will be able to get back to you. For next steps in the coming days, we'll be sharing the recording from this webinar. We'll also be sharing with you the slides from today's session, so that you can revisit and, look at what has come out of what has been presented today. We will be holding a follow-on webinar next month, and we will start diving deeper into the issues. Just please stay tuned and let us keep in touch. When we send you all this information, we will try to continue the conversation online by email, but then have more of it during our next webinar. Thank you so much. And like we say in East Africa, asante sana. Have a good day, rest of your day. Bye.